Uh, so first of all, thank you, Professor Forde, for giving us such a comprehensive and insightful speech on the target therapy and neoadjuvant therapy in non-small cell lung cancer. So regarding your speech, I have two questions regarding the neoadjuvant treatment for non-small cell lung cancer. And first of it is I noticed that you just mentioned that CheckMate A16 study, it did an exploratory analysis on the dual IO chemo-free neoadjuvant strategy in the design, which is quite a bold move. But we worry that the chemo at this stage will compromise patient response. And when it comes to clinical practice, which kind of patients or what specific features will make you decide to do a chemo-free neoadjuvant treatment for this patient? So this is my first question. And the second is also regarding the neoadjuvant treatment, but it's actually following Professor Shi's comments just now. It's for the patients with oncogene mutation, because we know that patients with oncogene mutation, they do not usually respond well to immunotherapy. So we know that we have evidence on like neoadjuvant EGFR TKI, which is not quite successful, but neoadjuvant ALK TKI is quite promising. And we are currently work with Novartis to conduct a phase 2 trial investigating the neoadjuvant BRAF TKI and MET TKI for patients carrying this specific like BRAF3 600 mutations and MET exon 14 skipping mutations. But what we found is that surgeons are quickly losing their faith in neoadjuvant treatment TKI. So the patient recruitment is quite difficult. So I would like to know what's your take on this issue. I mean, should we continue to explore like neoadjuvant targeted therapy in patients with this specific oncogene mutations? And if we shall do so, like which kind of oncogene you will prefer using TKI instead of immunotherapy, except for ALK positive patients, because you just mentioned that you will not use them. So thank you very much.
Yeah, no, thank you, Professor. Yeah, I think to your first point, I think the use of single agent immunotherapy in PD-L1 high disease, for example, is something I'd like to explore because it would avoid a lot of toxicity. And I think it could potentially be very beneficial. We're in the process at the moment of starting a study of neoadjuvant PD-1 VEGF in patients with node negative stage 1 and 2 disease. So patients who have node negative disease, where you have some equipoise about upfront surgery versus neoadjuvant therapy. We're offering those patients PD-1 VEGF bispecific as a neoadjuvant therapy without chemo. So I think that is a group where I would be comfortable considering the possibility, if you had PD-L1 positive or high disease, omitting chemotherapy as part of a trial. There are definitely patients for whom, kind of practically speaking, when you see them, they might have a history of smoking, they may have PD-L1 95%, and you know that patient is probably going to respond to PD-1 alone and the chemotherapy is doing very little. But we just don't have enough randomized data really at this point. So in general, I don't omit the chemotherapy. I will have a low threshold perhaps to drop the chemotherapy if I give a dose of chemoimmunotherapy and the patient has a lot of toxicity. I will consider dropping the chemo and just doing 2 or 3 more cycles of immunotherapy prior to surgery. But I generally try and give chemotherapy as well. And then to your second point about the oncogene addicted tumors, at least in the US, I think the academic centers still are quite strict in that they will not use chemoimmunotherapy in the neoadjuvant setting for EGFR, ALK. For the other alterations, it's variable, I would say. I think the 2 ones that stand out where there's a debate about whether immunotherapy is the best option or not would be BRAF V600 or potentially MET exon 14, because some of those patients will derive benefit from immunotherapy. But for example, tumors like RET, ROS1, potentially NTRK, I think those tumors were just, it's less likely immunotherapy is going to help them. It's not impossible. And we really don't have the data one way or another. So I would say to surgical colleagues, I think it's something we have to explore. I think chemoimmunotherapy is not the answer for every patient in the neoadjuvant setting. I think we have to individualize it. And I'm looking forward, as I mentioned, to seeing NeoAdora, because that'll be the first kind of global phase 3 trial where we're looking at neoadjuvant TKI plus chemo or TKI alone and seeing what the outcomes are. So I think if it's ever going to be successful, it'll be in that trial probably.
Okay, thank you. Thank you, Professor Patrick.
Okay, it's my turn.